diabetes. Symptoms of diabetes plus casual plasma glucose concentration or the fasting or the random plasma glucose of more than 200 milligram per dl, or fasting plasma glucose of more than 126 milligram per dl or 7 millimoles per liter, or 2-hour post-load on OGTT is more than 200 milligram per dl. Any one test should be confirmed with the second test, most often a fasting plasma glucose test. This criteria for diagnosis should be confirmed by repeating the test on a different day. So 2 tests should be done, and then it should be repeated on some other day as well to confirm the diagnosis. Any of these 3 can be used when, and one of them is, and the second test which should be done should be preferably a fasting plasma glucose test. So how do you categorize the glucose test status? Fasting plasma glucose is normal when it is less than 100. It is called impaired when it is between 100 and 125. And it is diabetic fasting plasma glucose. Patient is labeled diabetic if a fasting plasma glucose is more than or equal to 126 milligram per dl. 2-hour post-load plasma glucose or oral glucose tolerance. Normal plasma glucose is less than 140 post-load. Impaired is 140 to 199, and patient is diabetic if the levels are more than or equal to 200 milligram per dl. So we have talked about this. Type 1, polyuria, polydipsia, polyphagia, the clinical presentation, weight loss, weakness, and dry skin. And this ketoacidosis can be the very first presentation of type 1 diabetics. Type 2 diabetic patients can be asymptomatic, can have polyuria, polydipsia, polyphagia, polyfatigue. They will be having weight gain. When type 2 diabetic patients who is on treatment starts having weight loss, develops the polyuria, polydipsia, then you have to consider that they are now developing insulin insufficiency, insulin deficiency, and now they will be needing insulin treatment. Most patients are discovered while performing urine glucose screening. So most patients discovered while they are performing urine glucose screening. Excuse me. So what are the desired outcome? What do we want in these patients? We want their symptoms to be relieved. We want the mortality to go down. We want to improve the quality of life. And most importantly, we want their microvascular and macrovascular complications to reduce. The risk of having them is reduced, and the damage being caused because of diabetes is reduced. What are the macrovascular complications? It's a coronary heart disease, strokes, and peripheral vascular disease. Microvascular complication is the retinopathy, nephropathy, and neuropathy. We'll be talking about them in my second lecture. So how to treat these patients? A very busy slide. You can see very important, very important for the clinicians. What is advised is you start with monotherapy unless the HbA1c is greater than or equal to 9%. So if it is more than 9%, then you have to consider the dual therapy. Or unless the A1c is more or equal to 10% and the glucose levels are more than or equal to 300, or patient is markedly symptomatic, consider combination injectable therapy. That is the insulin or non-insulin injectable therapy you have to think of. So if the HbA1c is less than 9, you start with the monotherapy. But starting before going off to this monotherapy, the first thing you have to do is the lifestyle management. So lifestyle management at any level of HbA1c is the first line of the treatment. You have to advise to them. So if HbA1c is less than 9%, it's 6.5 to 9%. Actually 6.5 to 7, you can advise the lifestyle management, you can see, and then from 7 onwards you give metformin. Metformin is the first line drug. metformin, which comes by the name of glucophage or nuphage, is the drug which has to be given. Initially, it was said to the obese patients, but now obese, not obese, type 2 diabetic, start metformin to these patients. It is found to be very effective, has low risk of hypoglycemia, do not cause weight gain, and it usually helps in weight loss and keeps the weight normal, so it doesn't have a bad effect on weight. The main side effect is the gastrointestinal effect, so it causes GI disturbances. Lactic acidosis is also mentioned, and it has not been seen that much, but it causes lactic acidosis. If A1C is not achieved, you give metformin for 3 months, and if it is not achieved for 3 months then of monotherapy, then you do a 2-drug combination. Order is not meant to be to denote any specific preference. You can do any one of these, and this can also these drugs, there's a list of these drugs, and you can choose any one of them depending on the patient and patient's requirement and patient's condition. So one of the drugs, like sulfonylurea, you can give to the patient if the patient is not obese, because sulfonylurea can lead to the weight gain. And a patient who has heart failure, you will not consider giving thiazolidine diones to this patient. Then a patient, you can give DPP-4s. These SGLT2s have shown those with cardiovascular disorder, you can give them. Those having ischemic heart disease, then SGLT2s have been considered better option. It's a better option. Here there is a GLP-1 receptor agonist, which have a very good side effect, that is weight loss. So they help in weight loss. So on all those type 2 diabetics who are obese and they need weight loss, you can start with GLP-1 to them. And then the insulin, basal insulin, can also be added to these patients. Again, you give the combination metformin plus sulfonylurea, metformin thiazide, metformin or DPP-4, so metformin or SGLT2, so metformin and GLP-1, or metformin or insulin, whatever combination you're giving. You see these patients for next 3 months with the dual therapy, and if not responding, you proceed to the 3rd drug. And this, again, the order is not like this one and then go to this and then this and then this. No, you can choose according to the patient's requirements. So if HbA1c not achieved approximately 3 months of triple therapy, and patient is on oral combination, move to basal insulin or GLP-1. So you have 2-3 options after that if on triple therapy it is not helping. So what you can do is you can move to basal insulin or GLP-1 receptor agonist, or you can go to GLP-1 receptor agonist, add basal insulin, or you can optimally titrate basal insulin and GLP-1 or mealtime insulin. So you have a lot of options. You can juggle between the drugs as the patient, looking at the response of the patient. So how will you give the combination injectable therapy in type 2 diabetic patients? So what you do, you will basically do a basal insulin. So what is a basal insulin? Is the insulin which will cover the basal levels, which will give insulin, you give the insulin for throughout the day. So one dose in an agent which will cover the insulin, the basal levels of the insulin, not the parendial. So parendial is what insulin you give with the food, that is the parendial insulin, and the insulin which you give along with for throughout the day, which gives the coverage for throughout the day, not thinking of the food patient is taken, is called basal insulin. So you start with the basal insulin with metformin or other non-insulin agent, and if HbA1c is not controlled, you go to a you add a rapid acting insulin, the insulin which controls the parendial sugars, that is the sugars rising after taking food, or you add the GLP-1s, or you can change to pre-mixed insulin, so a mixture of insulin which has the rapid acting insulin and long acting insulin, you can give them. So we're going to come to these insulins and we'll talk about them. this is how it has been advised how the therapy should be done. So don't get confused. We're going to come to these different type of the insulins in the later slides, and then you can come back to this slide and have a look at it. Then you will understand it much better. So what is the impact of intensive therapy for diabetes? So there have been several trials which have been done world over. The major trials which have been done are UKPDS and DCCT and Accord Advanced Reddit. They are mentioned in your books. You can go through them. What the main thing we have come to know about is that by intensifying the therapy, what they saw that all the microvascular, that by intensifying therapy, there is a very good effect on the microvascular complications. So all microvascular complications are controlled by intensifying the therapy for diabetes. But we're not sure about the macrovascular, and we are not sure about the mortality as well. It has not good effect. It has not significant good or bad effect on mortality. It has also been seen in Accord, it was seen that there was excessive mortality by intensifying therapy, and this excessive mortality was actually because of the increased hypoglycemic episodes in these patients. Intensifying the therapy led to hypoglycemias. So that's what we need to be very careful about. uh, the main complication we have to be very careful in these diabetic patients when we are intensifying therapy is hypoglycemia, because that can lead to increased mortality. So what are the anti-hyperglycemic therapy or glycemic targets? So HbA1c should be less than 7, preprandial glucose should be 80 to 130, postprandial should be less than 180. So before meal or fasting should be 80 to 130 on treatment, and after meal it should be less than 180. We have to keep it in a way that there is no incidence of hypoglycemia. Whenever there is hypoglycemia, we have to loosen the control on the glucose. This treatment has to be individualized. It depends on patient to patient. You can go for more stringent kind of control from 6 to 6.5 if duration of the disease is short. If it is a younger patient who is very healthy, very motivated, has no complications, no cardiovascular disease yet, you can go you can you can go for a stringent control of 6 to 6.5, and you can go for less stringent from 7.5 to 8 if the patient has several comorbidities, if there is hypoglycemia, if he is old age patient, if they is less motivated, doesn't have support, or has limited resources, then you can go for a less stringent control. So this is what I see, that even if we keep the glucose at HbA1c target less than 7%, we see that the control patients, many patients are not at this recommended goal of HbA1c. So there is ominous octet of DM2. Diabetes mellitus has ominous octet. This is the mechanism by which hyperglycemia is taking place in diabetes mellitus type 2. So we have impaired insulin secretion, and there is increased glucagon secretion, which we have talked about. There is increased high glucose production by the hepatic glucose production. By the liver, there is increased glucose production. There is neurotransmitter dysfunction. There is decreased glucose uptake. There is decreased glucose reabsorption, decreased incretin effect, and there is increased lipolysis. These are all the pathways which are responsible for the